Our next panel will explore some of the tactics and policy solutions that our state and federal leaders are pursuing to prevent and respond to addiction. To moderate, we have someone who's no stranger to this issue, former Massachusetts Attorney General Martha Coakley, who spent most of her career in public safety as an assistant DA, as the Middlesex DA for 8 years, and more recently as the Commonwealth's Attorney General for 8 years. While she may no longer be in public office, the good news is she is now a New England Council member, having joined the law firm of Foley Hoag earlier this year. So please join me in welcoming our next panel and our Moderator General, Martha Coakley.
So good morning, everybody. Thank you to that first panel. That was very enlightening. I will make a note that we had age before wisdom, right? Because we had all men on the first panel, all women on the second. I appreciate the chance to be here, and I will just say quickly that starting as an assistant district attorney back in 1986 in Lowell, a lot of our caseload involved heroin addiction, use of needles, and fast forward all the way up to recently where we know how extensive this is. You heard from Maggie Hassan, you heard from Ed Markey, you heard earlier, you know it's happening in every community. A realtor recently told me that when she has an open house, the parents go on the first floor and the kids head up to the bathroom to see if there are drugs up there. So it's clearly a crisis. I'm going to quickly introduce our wonderful panelists and get right to questions. First, on my left, my friend and colleague Rachel Caprillion, the New England Regional Administrator for the U.S. Department of Health and Human Services. She previously held several leadership positions in Massachusetts state government and served in the state legislature for 13 years. To her left is Dr. Monica Burrell, our new commissioner of the Massachusetts Department of Public Health and a member of Governor Baker's Opioid Working Group. To her left is Dr. Marian Delphin Rittman, the commissioner from Connecticut, the Department of Mental Health and Addiction Services, and an assistant professor of psychiatry at Yale University. And to her left is Maria Montanaro, the director of the Rhode Island Department of Behavioral Healthcare Development, Disabilities, and Hospitals, and the co-chair of Gina Raimondo's Overdose Prevention and Intervention Task Force. So let's get right to our questions. Rachel, a few weeks ago, President Obama announced new steps that the administration would be taking to address opiate abuse. Can you tell us specifically about the steps that are being taken at the federal level by HHS to help tackle the opioid crisis and support the states?
Thank you, and it's great to be here. Just when you think you have not a lot more to learn about the opioid crisis, you learn still a lot more. And I can say safely and certainly that there is no bigger priority of this White House, the President Obama's administration, and Secretary Sylvia Matthews Burwell than getting control of this out-of-control issue of opiate addiction. Secretary Burwell herself comes from West Virginia, another state where this is a particularly acute problem. But it is certainly not just New England, it is certainly not just West Virginia. Where it's not a problem right now, it is quickly becoming one. And it is a matter that is going to require all of our efforts working in harmony so that we can begin to stem this tide and then begin to help all the people who are in this condition to get better and be in recovery. President Obama traveled to West Virginia on October 21st, where this was the subject of a major speech. And it's multi-pronged. And when the question is asked, what is the federal government doing? It's more like, what is the federal government not doing? We need to have all the good ideas, all the best practices from all of our states, from an opioid summit of all 50 states that took place in September that I know my colleagues were also in attendance, to what we're doing for medically assisted treatment, what we're doing for education, and what we're doing to help people once they are in recovery, stay in recovery. There's a saying that detox is solitary, but recovery is community. So it's all of our responsibility as a community to help people stay off of these very serious drugs. So the first prong, of course, is community prevention and education, and that includes what's happening in our federally qualified health centers, aligning the federal resources with actually access to treatment. We are very lucky that with the Affordable Care Act, everyone now has access to mental health and substance abuse treatment. This is a major component of what we're able to do that is different in this day and age to help people find access to care. And that adage that all medical care is also local. People need to find it in their communities. My role includes all of New England. There are people in parts of Maine that are 100 or 150 miles away from a medical facility. How are we going to do things remotely? How are we going to ensure that people have that access? Beyond the Affordable Care Act, HHS is investing up to $100 million to expand substance abuse order treatment with a focus on the medically assisted treatment. And the odds that a person will get into recovery, stay in recovery with medically assisted treatment, it's far greater outcomes. And of course, the enforcement and supply reduction, working with the Department of Justice, working with law enforcement, shutting down pill mills. This is a international problem, as was described in some of the earlier speakers, and supporting, of course, federal legislation that helps improve the odds of where we are now. And Senator Markey's bill is one heck of a place to start. So with that, I could go on. I'm sure there'll be a lot more interaction. So we are working hard, and probably most importantly and effectively, the federal government has an awful lot of grants, has an awful lot of money, and they are certainly looking at creative ways of how states are able to access help in this arena. Vermont, for example, has a Medicaid waiver where they have therapeutic daycare for babies who are born addicted and their mothers. So that is another very creative way of tackling a very real on-the-ground problem. And I cannot say enough about the governors in New England. We are leading the discussion. We are leading some of the innovative ways of treating this, and we're looking for good ideas. And I am here to say that I am very glad to make those cases wherever I can and wherever any of our federal partners can at the federal level, because we need to get our odds a lot better than they are, because we are not winning at the moment. There's a lot of great things in place, but there's a lot more coming in. Thank you.
So thanks, Rachel. So let's turn to what's happening at the state level, because it's much more granular. You're seeing what's happening on the ground, and those innovative ways that both we saw earlier, the private sector and private-public partnerships are working to address it with their data. I think we can learn from what the states are doing and then go to Rachel and look for money, right? Is that what you just told us? So
That's what I said, yeah.
So Dr. Burrell, you served on Governor Baker's opioid working group, which presented a detailed set of recommendations earlier this year, many of which have been incorporated in the comprehensive bill that he just introduced last month. So could you tell us today about some of the key pieces of that bill that you believe will help combat this crisis?
Sure. Good morning, everyone. It's great to be here with you today. Thank you for taking on this important topic and bringing it to the council. It's with all of us speaking about this in this way across sectors that we're really going to make a dent. So as many of you know, Governor Baker took this on extremely early in February. We came together as an opioid working group chaired by our Secretary of Health and Human Services, Secretary Sutters, and came up with 65 recommendations and an action plan for addressing this issue. So I just want to frame for you as I talk you through a couple of them. Don't worry, I won't go through all 65. Just to frame this issue a little bit. So number one, substance use is a chronic medical disorder. And from my many decades of working on the front lines with individuals suffering from this disease, I can tell you that many people talk about the choices that individuals make, and there may be some early choices that are bad decisions, but I have never met anybody with substance use disorder who is happy with this so-called choice. So this is a disease. There's immense suffering to individuals and community members associated with it, so really critical for us to reframe this as the medical disease that it is. Number two, the silos that we work in right now, whether they're in the medical community or in the public health community or in our general community, the silos are really making it difficult for individuals to get the care that they need. I can tell you that when I would wheel a patient to an emergency room with chest pain, there were 3 doctors, 3 nurses, emergencies services quickly going into place. When I would wheel somebody over who was acutely detoxing from a substance, the response was very different. Oh, Charlie, you again. Sorry, we don't have a bed available. So it's really this, we together have to start shifting the way we think about this, and thinking about stigma. The stigma associated with this disease is really a critical piece of that. And then I'm really convinced that we're not going to be able to successfully address this public health epidemic until we work across sectors. So of course that has to involve healthcare, and of course that has to involve public health, but it's going to take all of us. And whether that's employers or educators or community members, we have to work on this together and from every angle, because no one group can do this alone. So thinking about those 3 principles, the way we approach the governor's recommendations were to look across the spectrum of prevention, intervention, treatment, and recovery, and ensure that we were addressing all of those in our recommendations. So in the area of prevention, it's really about decreasing the supply of prescription drugs as well as the demand, so education for people before they begin to use opioids. So in our work with prescribers, you've heard a little bit from Dr. Dimitri about our work with the Mass Medical Society, and we're working on education, actually today releasing the medical student core competencies, which will really be a first in the nation of medical schools coming together and then working from there to practicing physicians as well to do education and also to improve the tools available to prescribers, including the prescription monitoring program. And we're right now under procurement to improve that program so that the system can better integrate into clinical practice. In terms of education at the community level, we really need a full shift 2 ways. One is to make sure that we all see this as a disease, and we have an anti-stigma campaign that we just launched in Massachusetts, a state without stigma, last week. And then 2, to ensure that when individuals need treatment, it's available and that they know where to go for that. So it's education on multiple levels. In the intervention area, we're really working hard. We were one of the first states to use Narcan. You heard about naloxone being discussed earlier, and we've worked now to allow municipalities and communities to buy that at a lower rate for bulk purchasing. We're also intervening by ensuring that data is available. So before February, we had opioid death data available in Massachusetts with a 2-year lag. And now we're releasing that on a quarterly basis, and we're constantly working to improve that information so that not only healthcare workers and hospitals and clinics, but also communities can understand where there are hot spots and areas that need attention and increased resources. In terms of treatment, we understand that there must be access not only to more beds, but also to more medication-assisted treatment, and making sure that individuals get, just like we're moving in the rest of our medical community to making sure that an individual gets the right care at the right time, at the right place, making sure that we don't have a system where it's a one-door entryway only if you need assistance with substance use disorders, but getting the right treatment at the right time. And then finally, as we support individuals in recovery, making sure that they have enough access to community-based services and working with our community partners to ensure that. When you look at the governor's bill that is out now, you'll see some further enhancement of that, including restriction to 72 hours of new prescriptions and the ability to hold an individual involuntarily for 72 hours as opposed to them going through the criminal justice system. I'll stop there, and I'm sure we'll talk further. Thank you.
Thanks, Dr.